الحمد لله رب العالمين. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. يسعدني ويسرني اليوم أن أستضيف الدكتور ياسر طب في محاضرة متميزة جدا جدا عن treatment management of cancer pain، وأنا متأكدة وواثقة مليون في المية إنها محاضرة هتبقى outstanding. طبعا لان احنا زي ما كلنا عارفين ان دكتور ياسر لا يدخر وقت ولا جهد ولا مال انه يعلم ويتعلم. فربنا يديم عليه نعمه وستره وعافيته في الدنيا والاخره، اللهم امين. واشكره جزيل الشكر ان هو لا يألو جهدا اللي هو يلبي الدعوه في اي وقت للمحاضره، وجزاه الله عني وعن الجمعيه خيرا يا رب، اللهم امين. وربنا يبارك في صحته. Our topic today is recent advances in the management of cancer pain by ياسر محمد رضا. تفضل حضرتك دكتور ياسر.
بسم الله الرحمن الرحيم. Thank you, Dr. Safa. Thank you for all the attendee which spend the time and the money come to share with us this important topics. I know we started the pain management long time ago with Dr. Omar Tawfiq, when the pain management was cancer and non-cancer. Cancer pain was people dealing with cancer, and I am proud because I started my career at National Cancer Institute. And the non-cancer pain was at that time was usually a very minimal types of low back pain, but the pain branch extended, become musculoskeletal, entrapment syndrome, ultrasound. So everything is growing very fast, like a tumors. So I don't have any conflict of interest or any support from company or from any society or association. This is my beautiful city, Ras Al Bar. My objective today for the presentation, I will give you a brief introduction and how to evaluate a cancer patient with cancer pain, management option available for cancer pain, and I will just go for the evidence about management, which is lacking all the time because sometimes an ethical study to be done. Also interprofessional team strategy to improve care coordination and home message at them. So every time when we speak about pain, we speak about that the pain, unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in the term of such damage. It is a little confusing definition. In a simple way, that the pain is not just sensory, it is an emotional affection at the end. And this is the definition was until from 21 until you know that they make some renovation to add more confusion for the definition in 2020 when they said about the definition of pain, unpleasant sensory and emotional experience associated, or this adds this words between the arrows, or resembling and associated with actual or potential tissue damage. Really, it adds for me at least more confusion. But in easy way, you can feel that this bread is sad or have a pain. And the this barrel, even with one eye, is smiling. So the definition of pain or expression of pain is hardly to describe. And another problem about pain, you don't have a measurement like blood pressure, like temperature. So it is a subjective sensation. I guess you can agree with me when you see no pain, no gain, but really it is not right for pain management. If you have pain, you will not gain anything. It may be in the life. And you agree with me when I tell you that the pain is subjective, being underestimated all the time, any type of pain, and being undertreated all the time. And at the end, you agree with me when I tell you in the end, no one remember Krebs cycle. But you must remember the pain is, you know, I have many patients with, you know, mid-zone for age, but when coming to a clinic, he feels that he's a very old man, as the pain is just leaving the body. When you have a pain, you can grow very fast to be an old man. So the risk factor for cancer and for pain, which is produced by cancer, the main risk factor, if you have more cells and more time, you can get a chance to get a more susceptible to be a cancer patient. But the most 5 leading cause of cancer in the world, tobacco was about 22% of the people who have a cancer have tobacco. And the remaining percentage of risk factor of cancer, like high body mass index, obese people, sedentary life, which use all the time canned food, inadequate fruit and vegetable intake, and alcohol use. Those people are susceptible to be a cancer patient. Again, with cancer, especially in the late stage, you can find many statistics about how much patients have moderate to severe pain at the end of life or just when advanced cancer. It's about 55% for people treated in cancer pain, get cancer pain. At the end, it may be more, 60% or even more. This statistic came from WHO. But in other study, you know, in advanced stage, you can find 70 to 80% of the people feel a moderate to severe pain. Different figure from different study, but it is a very high incidence to get a severe pain at at the time of when you get treated from the cancer. Unfortunately, most of the time, recorded pain is severe, and this is one of the worst pain. And sometimes the patient die from pain, and scare from pain than scare from the cancer itself. So the meta-analysis, including study between 2005 and 2014, over half cancer patients received anti-cancer treatment. And sometimes this anti-cancer treatment is a treatment of pain also. 2/3 with advanced and metastatic cancer have a pain, about 60% like the other statistics. So globally, cancer is the second leading cause of death. 70%, about 10 million or 9.6 million cancer deaths affected the world every year, especially in low socioeconomic country. Highest incidence is lung, breast, and colorectal and prostate. And I think in Egypt, especially my area, Damietta, have a very high incidence of cancer breast in young age people. And this is the second cause of death after heart disease. What is the barrier against to treat a cancer pain? Sometimes, all the time, I tell you that the patient don't get a good evaluation or good treatment, and usually being underestimated, undertreated. What is the barrier against treatment of pain? First thing, it is a physician-related. Most of the physicians, which deal with cancer all the time, have a limited knowledge about pain pathophysiology, why pain happen, and why is the character of pain different from one to one. And again, inadequate assessment. This is a second barrier, or limit assessment scale. He don't get a professional training to deal with this type of pain. And also bias against opioid therapy, scared about opioid therapy can produce problem for the patient, but really it is not a cancer patient. And fear of irregularity, security, is fear about any what's called regulatory issue from the government. The second barrier is the patient itself. And they can give him the name Googleopathy. The patient read everything on Google and is scared about the have a lack of education and also improper dosing and intervention. When he read about side effect, he don't know that the side effect increase was high dose and also prolonged use for the medication. A concern about opioid and addiction, and patient compliance and expectation about the management of pain. Again, the third barrier against management of pain is system related. Because usually low priority is given to pain management because we don't see the pain. If you have a swelling in your face, everyone sympathize with you, want to help you, but the pain, no one see it. This is a problem in the system. Limit number or refill allowance, give you a medication for every month or 2 months like here, and they don't give you any more if you need. A strict policies and the guidelines, and sometimes make a restriction for the medication. This is a very interesting picture. I found it in the internet in 1907. And this is the sealer for mummies. This man brings some mummies and was sealed like this on the street. So I can give you a few rules to help you how to diagnose or how to treat the cancer pain. Especially we don't have a great evidence about pain management. So first rule, any pain in cancer patient still is a cancer until proved otherwise. What I mean by that, any patient treated or follow up or just start treatment and have a pain in any part of the body is cancer until proved otherwise. you must searching for a cancer. And we found many cases here in my practice like this. The patient cured for 10 years or 5 years, 7 years, and come back pain or sacroiliac pain, I found metastasis. So any pain in cancer patient is cancer until proved otherwise, and must make a thorough investigation for that. Again, don't forget that the cancer patient is not immune against other type of benign pain. He can get any type of benign pain, disc prolapse, entrapment, carpal tunnel, whatever. So both the focus first to exclude the cancer, and after that, he can get any benign pain. Remember again, the pain is dynamic. The cancer pain is dynamic, and sometimes very difficult to classify, because some cancer pain becomes severe before 3 months. So you can see the acute or chronic, and what's the difference, or sometimes acute on top of chronic. So the cancer pain is dynamic in everything, in the site, size, character, severity, and everything, associated symptoms. So it's a dynamic action of this pain must be dynamic in your management. Again, neurotic intervention and life expectancy. Don't make a neurotic intervention or destructive procedure for a cancer pain if you have what's called long life, or the life expectation of the patient will be more than 6 months to 1 year, because deafferentation pain will happen, and after that, this pain is so severe and no one can treat it. And at the end, if you can't do anything for the disease for the patient, let the patient to die in base. And I will just later I will speak about terminal cancer pain, which is 10% was not controlled by different medication. So the cancer pain syndrome, it may be the pain came from the tumor itself. Sometimes came from the tumor itself. When you invade a bone, muscle, destroying the whole organs, it is about 70 to 80% of the pain. Sometimes the pain came from the management, like a surgical postoperative pain, come from chemotherapy when we can peripheral neuritis, or radiotherapy when we can peripheral neuritis, or we can and destruction for pain or edema for the spine. Or sometimes come unrelated to the cancer, as I told you before. It may be an associated disease like diabetic neuropathy, post-herpetic neuralgia, anginal pain, joint pain, and myofascial pain. The first step of management of the pain, whatever the pain, cancer, non-cancer, to make a rapid communication between you and your patient. The patient must feel that you are one of his family, not just a doctor looking mask face. You must cooperate with him and to tell the patient, I feel two person can feel your pain, you and me, because I'm a preventive physician. This is a first step to get the rapid communication with the patient. Again, to go for a comprehensive history to see which type of cancer the patient was treated from, what the medication, which time started the management, and is management related to pain or not, and like a physical examination and pain syndrome diagnosis. So you assess the patient by himself, and again you assess the pain. Because at some pain at the end, he may need a surgery, he may need a radiotherapy, he may need a physiotherapy. I can tell you, and one of patient from I think, one of my colleagues, his relative, and just to go and have a sacroiliac pain. She's a cancer patient, breast patient, but for 7 years follow-up, don't have any problem. And one of our colleagues, without any investigation, go to make a sacroiliac injection. And after making sacroiliac injection, the patient started to gain a pain until 10 days, start to take a morphine. I tell him, you must get another thorough investigation. He made MRI. He found a very big mass, paraspinal mass, extended from about 10 on 15. And I tell him, this patient will not be treated by our medications. They send the patient for radiotherapy, and after 2 weeks, the patient improved dramatically. So we don't treat by our medication only. It is not one-man show. So assessing the pain to diagnosis, stage of the disease because of life expectancy, and response the patient for cancer pain management, or even pain management, response to pain treatment. Sorry. We have many assessment tools for the pain. And the easiest way, like visual analysis score, verbal rating score, numerical rating score, but this is an assessment called unidimensional. There is other multidimensional to assess the affective, the psychological, and everything. But this is a simple way just to ask the patient about his pain, if you put him, for example, from 1 to 10, 10 is most severe pain, 0, no pain. So this can give you a clue about the pain. Again, as I told you, the pain is dynamic. So a dynamic in character, it may be different type of pain. So in pain examination, a simple question about the pain. First, how severe is your pain as different from 1 to 1? What type of pain? Stabbing, dull aching, burning, stitching, because I can know the character of pain, and every pain respond to some medication better than others. And where you feel your pain, related to cancer or not? What brings the pain? What brings the pain may become severe, and what relieves the pain? You know, and some medication help or not. And many things just can relieve the pain, like position, like medication, massaging, hold back. And the problem with this assessment is sometimes it's very difficult in old age and which have a bad cognitive function, and they can report in the pain, and also for pediatric. And later, inshallah, I can speak about the cancer pain or pain management in pediatric and old age. And sometimes use an Wong Barker for pain drawing to draw the pain for the kids, and they draw by different color, and sometimes it's very successful to guide to the severity of the pain and character of the pain. And don't forget all the time psychological impact, because usually psychological impact increases the pain, and pain increases psychological impact, and usually going to the vicious circle. And this is a guideline for adequate assessment. Assess and reassess the pain after medication, assess and reassess the patient after treatment, assess and reassess your ability to form the communication with the family and the patient. So the cancer pain may be categorized in 3 types, which we know: neuropathic, somatic, visceral. And most of the time, this pain is mixed between these 3 types. Very rare to find one pain, but sometimes you find one pain predominate on others. So, and if you found the pain at that time, samples is not enough. If you feel to plan, you plan to feel, you must plan to something. And we know that because no one fit all, and now we have a many option every year. When I start my career, we have a little limited option to treat the patient, but now we have many options to treat the patient. Whatever used to treat the patient different between schools, safety is paramount. Safety is paramount. Not to do and something you don't do it and you don't know it about the patient in emergency situation. So the aim of management is the quality of life. So decrease pain score can help quality, improve the function, improve sleep, being coping. You know, you can cope, but 1 to 3, by verbal score or roller score. If your pain was 8 and become to just cope with this pain, improve the psychological state. Unfortunately, sometimes when you treat a pain, we don't improve the quality of life in some study. So the pain is only part of the suffering. When you go for approaching the pain for patient with cancer, it is like a non-cancer, the chronic pain. You must help him social, psychological, spiritual, physical symptoms, culture, and pain. And I see what's called a report in the British Journal Anesthesia a few days ago. Dr. Yasser Zaghloul put it in the Facebook about one of the doctor physician. He speak about spiritual religion support for the management of cancer pain, because cancer he died a short time ago, and this published this report, and you can find it on the internet. If you go for Yasser Zaghloul, he put it, and it's very interesting to read. So the pain management, as I told you, this is a complexity of the pain and dynamic action for the pain. He need a multidisciplinary approach. You can treat pain by unimodal management, and he need also varieties of diagnostic and therapeutic modalities. The first thing about cancer pain or any chronic pain is education. If you educate the patient about his pain, what's going on, what happened in the procedure of pain, and what you will see, what's the expectation for the pain, and this is even education for 2.5 an hour can help you in a prognosis of your pain or severity of pain. This is the main thing. You just usually rush to do it, and it is a cornerstone of medication. The medication for cancer and non-cancer pain. It may be lifestyle modification can help also for chronic pain and also cancer pain. Exercise, but to be suitable for your disease. after rehabilitation, for example, after fracture from tumors and healing and fixation, you need some sort of exercise which is suitable for your. Also, look for the mental exhaustion. Without treating the mental exhaustion, psychological state, you don't treat the patient. Some alternative therapy like biofeedback to concentrate in something, it can help in many studies. Obesity as a cause of suffering or just a cause of cancer, increased incidence, must be treated. Smoking, especially for heavy smoker. Some to go for fresh air and to make a yoga. Not necessary to make it in this area. You can make it at home with yourself. Also, some aerobics and some dancing can help you and to move your muscles. And light, you must smile before you still have a teeth, is very important. And psychological determinants must go in for psychology to treat psychological aspect of pain, to cut the cycle of bad psychology, increase pain, producing bad psychology, and you must cut this. Some physiotherapy can help in some diseases. Some alternative therapy like massaging, acupuncture, cupping, different rehabilitation program. Teen therapy can be an adjuvant. And inshallah, in near future, it may be use an BRB or a stem cell, or it can be helped, but still the study not showing any good result. Marijuana or hashish have a very good rule for treating the pain and to prevent nausea and vomiting. And it's discovered now, but really we discovered in Egypt this before those people. This picture, left side picture, in Egypt and in Giza was cultivating and Babavir seminiferum. This picture in 1917. And this, the right one, this is an hashish qahwa mesh. This picture is taken in 1922. So it was started early and prohibited for a long time and returned back again. And the most important to treat the disability, whatever disability, sometimes disability is mental or the disability is physical, you must treat disability to treat the pain. So what is the option? Can you close the sound? Someone echo? What is the option for cancer pain management? So the cancer pain in the middle, and chemotherapy can be a treatment of cancer pain and for cancer and its pain. Neurosurgery can be treated the cancer and the pain also. Radiotherapy, the same. Pharmacotherapy. This may be other specialty, but pharmacotherapy, other treatment, nerve block, orthopedic surgery, palliative surgery. All this group of people can treat the cancer and the pain at this time, because if you treat the cancer, you treat the pain. So, but we have joining this team by many things like pharmacological therapy or intervention therapy. So the WHO put a stepladder system to make the guideline easy. But unfortunately, the stepladder system is not supported by evidence. And survey done for UK, they found that only 48%, about 50% of the people usually following the WHO ladder system because it have many mishaps. But it puts a simple way to how to treat the patient, but it suggests that the patient came early when he have a very minimal pain to go with this ladder system, and this not happen in practically. So the stepladder system, which is working for many years, it started by non-opioid, a simple analgesic, paracetamol, non-steroidal anti-inflammatory. If the pain going up, we can use a big weak opioid like tabindadol or tramadol. And if you go more higher, you can use a strong opioid like morphine, methadone, buprenorphine, and what's called the fentanyl patch. And this is a 3-step, but the 4th step or jumping step to go for nerve block, epidural, BCA pump, neurotic block, spinal stimulation. And if the patient not cured and it's 10% of the patient end of life, can we give him a sedation? So the cancer pain management came from stepladder system. It make an standardization and to adapt the regimen to need for the individual and to give some patient education, and also the role there to use the normal way for medication, to use oral. And when you use a transdermal and other route, when the oral route is not permissible. But don't remember, there is many other guidelines and different from WHO guidelines, like National Cancer Care Network, Center of Disease Control and Prevention in America, American Society of Clinical Oncology. You know, the guideline is different a little, or just a kind of different, different from the bladder system. And because we don't have really a very good evidence in pain management about chronic pain or cancer pain study to be done in human being, because this is an ethical. This picture, I like this picture. This is a picture from Al-Lisan, the tongue from Ras Al-Bar. And this is a map for the Nile, which started from many, many countries, 6,200 kilometers, until it come here to be on the right limb for Ras Al-Bar. And this boy is sitting on the sign of this is my grandson. So all the time, when you go for any subject and people asking you, what is the evidence? So according to our recent study, marriage is the main reason behind evidence. That's right. I agree with you. It's 100%. But remember that absence of evidence is not evidence for absence. Sometimes you don't have enough studies. Sometimes the study is very difficult to do because the human being. And at that time, you go for the personal expertise, the professional people, which is expert, and we get the guidelines from these people. And because of came from a low evidence, usually change every few years. And the problem that all the study done for chronic pain cancer been done for animal study, and not necessarily what happened for the animal can transmitted translated to human being. And again, if you need a randomization, it looks like when I ask you if you have you need an evidence for cancer pain, which you leave a patient without treatment and other patient with treatment, and this is an ethical can't be done. This is the same like when I ask you, is parachute saving a life or not? To get a randomization, to get a good study, you must send a big number of people without parachute and a big number of people with parachute, and to see save a life or not. And this is not happening usually in pain management. So I put in many studies here. I bring even some data from it about optimal management, pain management of patients with cancer in the modern era. And I found many, many review articles and chapters in book about cancer pain management, different from one to one, and no agreement as one is called. But he give you as that still the cancer pain not treated in a good way, not safe to treat a patient, and even in a well-developed country, you know, another adult cancer patient version. He said the same in patient need and multimodal analgesia as a concept of multimodal analgesia for chronic pain, and this patient guided and to be an a teamwork. So what is a multimodal approach? As we know, the multimodal approach to use different method at the same time to decrease the side effect of every method if you use one method, and to improve the quality of management. So the significant issue about the multimodal analgesia, it needs a team. It is not one man show. We started, as we said before, by medication. And the cornerstone for medication for severe cancer patient is opioid, is morphine, the father of all narcotics. And the goal of morphine or any analgesia, pharmacological analgesia, to get what's called a tolerable pain relief and a tolerable side effect, because sometimes you can't cure the patient completely, and to be a good quality of life. So pharmacological thing, you can divide it to opioid, which you can use, and non-opioid analgesia. Opioid therapy started by the cornerstone, which is morphine. Even morphine have many mishaps about chronic pain, but still the cornerstone for pain management, especially severe, moderate, and severe pain. And the aim to improve the quality of life, as I told you, that improving the pain, not necessarily to improve the quality of life. So we started by a strong opioid, like morphine, and there's a different form of morphine, SR, Rolaids, or IR. No difference between the quality of management between IR and SR, except the time only. And usually the patient can be tolerated from 25 milligram per day to 2,000 milligram per day from oral medication. So if you adjust your dose by IR, you can use an SR, because it takes every 12 hours, even 24 hours in some patient, and to be durable with the patient, so morphine. But remember that 40% of the patient is not relieved by three-step method for the WHO. And sometimes some patients have what's called pain-resistant opioid. It may be because of a different type, like bony pain, neuropathic pain, which is not improved by narcotics. So, and don't remember that opioid have a horrible side effect for long-term use, but still the best medication, but still have, in some patients, have many horrible side effects and can't be used in pain like muscular pain, decubitus ulcer, not effective in pain, fracture, bony pain, epidural compression, headache due to this intracranial tension, non-cancer neuropathic pain. All these types of pain is not effective with the use of morphine, even the strong narcotics. And also they have many side effects like constipation, nausea, vomiting, delirium, pruritus, confusion, hallucination, somnolence, sedation, myoclonic jerk, severe depression, opioid-induced hyperalgesia. You give the medication and you give high dose of medication and the patient feel pain all over his body and the pain increase. And just a hint for one slide about pain management during COVID crisis. We know that I think some echo. Yeah. Opioid therapy and have a problem with immune systems. They may have immunosuppression effect. But still, because it's strong, you can use this one only. And opioid inhibition, natural killer cell, make a problem to us, but really we don't have enough randomized control study in this time. But still, codeine, morphine, oxycodone was used in cancer patients during COVID crisis. Methadone is another drug, has a long half-life, taking from 10 to 40 milligram per day in divided dose, 5 or 10 milligram. If you compare to morphine, some studies showing that they have the same effect of morphine and less effect than morphine, but really when chronic pain, it is comparable to morphine and has this addictive power for than morphine and can be used for just to treat morphine dependency. Have a long duration of action, as I told you, and if you use it for a long time, more than 30 to 40 milligram per day, you must make ECG every 2 months, 3 months, and renal function, because this medication can go for dangerous type of arrhythmia. Transdermal opioid, the most common is buprenorphine and fentanyl. Hello? Fentanyl can be used, but remember when you use a fentanyl for cancer pain, it is not used for acute pain as people do. It's used only for chronic or cancer pain, and started to work about 12 hours or 24 hours from the starting and give plateau. The plateau is plasma level after 2 days, 3 days. And take care when you use this medication and to go to a hot bath because it can give you a lethal dose. And I know one of my patient to go for a bath with his patient on our team. He go on a bath, hot bath, and sleep on the sink, and he died because of overdose from the fentanyl. So fentanyl also have the same problem with morphine, synthetic morphine. He can reach the plasma level from 3 to 23 hours. Usually give a batch for 2 to 3 days. He give you a steady state compression, and it can be used for patients which can take an oral medication or don't like to take oral medication all the time. And if you compare to morphine, it is as strong as morphine. Buprenorphine is another drug can use as a batch. It is from 5 mic per hour batch, and it can be put every week. And we have until 20 microgram per hour. This medication is a good medication and can help also for neuropathic pain. Many studies showing that is more effective in neuropathic pain, also more than fentanyl. But the problem, the batch, when you put it, have a higher allergic properties, can give an allergy for a long time. And usually you put some anti-allergic and some ointment before that. So transdermal opioid, as I tell you, can be started with a very small dose for fentanyl, 12 mic per kg per mic per hours. Systemic concentration reach after, as I told you, 12 or 24 hours. So it can stay to 1 day or 3 days. Now we go for the week. I just go against the what's called bladder system, but I just give you medication by medication, because many people, 50% not agree for this for bladder system. So for example, if the patient comes in severe pain, I start from the bottom of the bladder or from up. I start from up. So opioid analgesic, the weak analgesic is called up because have a weak affinity to mu receptor. Sometimes if I use a very high dose of this narcotic, it will be very strong. The daily dose usually up to 400 milligram, but some people just give until to 600 milligram per day. Some guidelines suggested 400, some guidelines suggest maximum dose 600. And usually most of the drug can be used with paracetamol. Even the study is lacking because it is not an only drug to be used. And they have a big evidence recommendation. Some trial used, but most of the time used was in paracetamol. It is not effective as morphine in mu receptors. Tramadol usually treat mild to moderate pain, and have a role in the second step of bladder system WHO. The problem is take a long time to titrate the dose. And many physicians don't like to use it. He use a small dose of morphine and started. Codeine lost his role in management of cancer pain because it's a very weak medication. They changed to morphine at the end, but the evidence is lacking, and the nausea, vomiting, constipation is like morphine even more. Tapentadol, this is a new drug. Using mu receptors and selective noradrenaline reuptake inhibitor, even serotonin reuptake inhibitor, but is mainly selective, and they use for is a tolerable disease drug. He means as potent, not as potent, maybe more better than tramadol, because working by a little different mechanism from tramadol. Tramadol working in mu receptor and non-selective serotonin reuptake inhibitor, and it can be used in neuropathic pain also. The problem, most of the study done tapentadol with other medication, using other medication was that, and they found in one study it's not inferior than morphine XR, SR, or oxycodone XR. It is a center-acting drug, and now is used in high grades in cancer patients, have a very good analgesic property. Paracetamol, I will not just go paracetamol, because paracetamol as a drug have a minimal role in cancer patients. But many preparation of cancer patients like tapentadol and also with an tramadol, both and paracetamol with it, because to decrease the dose, to increase the efficacy as a part of multimodal analgesia. So I will not just speak about it a lot. Non-steroidal anti-inflammatory, it have a role in the bladder system, but don't forget the side effect. But the very interesting thing about this patient, I worked with this patient for many years, that the gastric irritation and kidney problem not happen as common as it happen for normal people. I think Allah will give him the power to resist for that, And the non-steroidal anti-inflammatory are very effective in pain like bony pain or back pain or due to metastasis, even sometimes more effective with a steroid more than morphine. So this is a picture drawn by one of the arts working for magazines that have a cancer pain, a prosthetic pain, and he draws this picture what he feel about the pain. So after that, we go for adjuvant drug. Adjuvant drug to help the analgesic medication or to help in the treatment or to decrease the side effect of the medication. So antidepressant and neuroleptics for seizure medication like tricycline depressant or gandapinoid can work, or selective serotonin and noradrenergic uptake inhibitor, and duloxetine, corticosteroid, bone strength like biphosphonate group or other group like calcitonin or other medication. Adjuvant drug, it used just to help to decrease the pain from neuritis from chemotherapy or neuritis associated with an cancer, and duloxetine, one of the drug used, and we use it here and can get a good result most of the patient. Pregabalin, amitriptyline, gabapentin also can be used for neuropathic pain, and it was a great help. And remember that most of the patients have many different type of pain, so you can't treat the pain in one medication. Now there is an hormonal therapy, and it is a very expensive, but can be used especially in cancer, lung, or some stuff like this. There is a hormonal therapy like tamoxifen and breast surgery. Bone syringe like biphosphonate, especially in lytic lesion. But this need more study, and there's desnumab, this is a new drug. But need a more study and comparative study to get an evidence, but it's used in high scale. Corticosteroid sometimes improve fatigue, nausea, and well-being, and help in metastatic cancer patient, and usually needed in 8 to 16 milligram day. And unfortunately, have a high profile side effect. Radiotherapy. As I told you about this patient which have a mass and have a severe pain, and give me sacroiliac and found this a mass, and this mass treated by radiotherapy. So radiotherapy have a very good impact for metastatic pain, for some type of cancer. And bony pain, as I told you, is very effective corticosteroid or nanosteroidal, more than the morphine and biphosphonate, even what's called salamon calcitonin. Surgery, it is one of the common management of pain because it is a cancer, but it is a very common cause of pain also, especially postoperative pain or pain coming after surgery. So what we can more offer the patient more is do all this stuff, and the patient still have severe pain. What we can do for this patient? So my advice, if you don't get a result from something, don't get it more, don't take more. You must go for another thing, what's called intervention. And the intervention can help your patient in some time if the regular medication not helping. But first of all, I know that what is the indication for intervention, and there is exception or not. The indication for intervention if the conservative management failed. You give medication, you give everything, but still the patient have a severe pain. Not durable with conservative method. The patient don't take a medication regular way. I don't like the medication or has side effect of medication. On type of cancer and life expectancy. I just write for this because of cancer head of pancreas. Because in cancer head of pancreas, if the tumor come outside the capsule, even with celiac plexus block, it will not effective like when you make it early. And this is one of the exception. It need to make it early when you discover the disease, because the life expectancy with the patient, even with surgery, which is Webel operation, it is just a palliative operation. It can be 1 year plus or minus. So it started early for this patient because life expectancy is not long. Also, if you have available hospital resources and guidelines and experience, also there is no other not other contraindication like infection, coagulopathy. What's the contraindication for intervention? Coagulopathy, we know that. Pre-existing neuropathy. Anatomical aberration, have a very advanced cancer, you can to go. Drug-seeking behavior, the patient have an addiction habits or have a psychological problem, or the pathology at the site of injection, or lack of experience of hospital facilities. So when I go for the procedure, I can ask you, what is the ideal procedure? Lifelong. It's okay, to be ideal. High success rate and selective destruction. It's okay, especially if it's done by even juniors. You don't need a senior to do it. Complete or satisfactory pain relief. This is one of the character to be ideal. Percutaneous by radiofrequency neurolytic. Under local anesthesia. No or minimal morbidities. Do we have this character for ideal procedure? We don't have. Really, we try to put a data to get to have this procedure, but with good training, you can get most of this in your procedure. So the target is very important. When you go for an intervention, the most important thing to go to the target, because this is an important thing to put your needle. Where I put my needle, not to make a more destruction for the area. We have many tools to use, like an image, which started by image, but now many procedures just going for ultrasound. For me, I just use an ultrasound about 85% for my cases now. So we have many bone intervention, intervention for cancer. I guess just enumerated. Like single injection, limited role of cancer because the cancer advanced, continuous spinal implant, destructive or interrupted pain pathway like neurolysis, local anesthesia, spinal cord stimulation, radiofrequency neurolysis. But the spinal cord stimulation, unfortunately, they have a very minimal role in cancer patient because locally, except if the patient have other type, with a benign pain or just neuropathic pain not treated. And we don't have a very big role for spinal cord stimulation, but some studies showing that some of cancer patients get an spinal cord stimulation. of cancer patient. Celiac plexus block, a very common disease for upper abdominal surgery, especially cancer of pancreas, and it help. If the patient is life expectancy around 1 year, it can be done, and it bring a good result. Superior hypogastric plexus, one of the sympathetic blockade for procedure, and it was done only when it started to be done. Celiac plexus block, I read about it. It's done for the surgery. The people which created looking to make it as anesthesia for surgery. Pelvic visceral pain, bladder, prostate, cervix, uterus, ovary, colon, and rectum. It can be superior hypogastric, can help with the pain, and it is between the bifurcation of the aorta and the promontory of the sacral promontory. This is some picture to show lateral and posterior, and make it by ultrasound and image ganglion bar in some diseases like perineal regional pain, cancer, anal pain, vaginal pain, and vulval pain, especially neuropathic pain. Percutaneous surgery frequency for advanced case like chordotomy, tractectomy, when you cut or you interrupt the pain pathway, spinothalamic tractectomy, trigeminal tract, nucleus, sphenopalatine lesioning, and others. Select ganglion block for cancer surgery, breast surgery for to relieve the limb pain. What's called localized somatic pain, you can in rib metastasis, cancer rectum, anal surgery, 70% success, and this is what's called dorsal rhizotomy, dorsal root interzone. It can be done by alcohol or phenol, and this is hyperbaric, this is hypobaric. I will not speak about the techniques. Spinothalamic tract, cross fiber, to know that cross fiber knows the same line, and it's done by CT usually, and it needs a radio frequency needle, and it needs a bone relation with the other section. Chordotomy, the indication, I will not speak about it because it's a very advanced technique, but you can see with an CT guided. I see, I hear echo. Can you close the phone? Again, there is a spinal implant can be done for cancer patient. There is many types. This Isomed, which give a continuous flow. Synchromed is a totally computerized, and some to get the shots, but usually Synchromed with advanced technology used now. This is a programmable intrathecal drug delivery system. It can be done for end of life or just a patient not can take a big amount of medication. And the difference between IV medication and intrathecal is a very big difference. For example, if I take 30 milligram oral, I take 10 milligram IV, I take 1 milligram epidural, I take 0.1 milligram intrathecal, so a very minimal dose and with low side effect, and can improve the quality of life with the patient. This is how to start it, and spinal cord stimulation don't have a major role in cancer patient. Nerve block is now have a major role in many places. Since there is what's called what's called peripheral nerve stimulation can be used, but still under investigation. No. I will just speak about two terms because you hear it a lot about cancer patient. What is a breakthrough pain? Usually you have a breakthrough pain during cancer patients. The patient taking medication, for example, morphine, every day, 8 o'clock in the morning and 8 o'clock in the evening, 20 milligram, 20, and his control very good. But he came at 4 o'clock, he got a severe pain in this time. Or some patient is very good all the time, but when he do some movement, he get a pain at the time. It's called this breakthrough pain. We don't know the real factor of it, the real cause of it, but we know that if you use a very short-acting medication working very fast, it can help, like sublingual fentanyl or the sublingual bullybop fentanyl or morphine, or very long-acting drug. So this is a breakthrough pain, and you look for that, or to adjust the dose, to give the dose, not just 12 hours, to give it more doses, to divide it by 3 days according to the breakthrough pain time. And as I told you, no consists about what's called a definition, but you can adjust your medication. You can formulate oral, buccal, or sublingual, or intranasal medication taken fast, working fast, and it can be preemptive. You know that the pain come at 4 o'clock every day, so you take at 3:30 the medication to help this what's called an pain. Another term you heard about it is called opioid rotation. For example, I take a morphine per day, 60 milligram. And this 6 milligram give me a very good relief, but have a horrible side effect. I can't continue with it. So I can change the indication with another opioid. But when it started by another opioid, it started by what's called the equipotent dose. But don't use a full equipotent dose. You take half of it or 2/3 of this dose. And because you don't expect the response. This is called opioid rotation. And to know that, you must know the equipotent dose for every drug. Morphine 10 milligram equal codeine, 100 milligram equal tramadol, 100 milligram oxycodone, 5 to 7.5 milligram hydromorphone, 2 milligram and methadone, 1 milligram. This is the equipotent dose. When it change, for example, morphine 10 to codeine, 10 to change it to 100, but don't start by 100, start by half of 2/3 of the dose. Sometimes after all this, what you did for the patient, and about 8% or 10% of the patient in a late cancer patient not controlled by all medication and taken morphine like and taken water. So near this, sometimes we do use it for him. The patient usually have an dyspnea, agitation, delirium, not controlled by medication, and suffering is be horrible with the family and the caregiver. And there is no result, no hope for cure. So it will be a sedation in a special hospitals until his death. So if you can't treat cancer pain, let the patient to die in base. And they can use a different medication like opioid, neuroleptic, benzodiazepine, barbiturate, even propofol. I know that I take more time for this issues, about 50 minutes, but it's a very important issue. I hope to get some of the data about it. And I know some of you left or just doing like this to finish. But what about the sweet conclusion? Cancer pain is a common but untreated, undertreated all the time. Assessment is essential. Tailor treatment to pain type. You don't follow WHO or any guideline and the patient still have a pain and tell me this is a guideline. Just you must tailor your management for your patient. Adjuvant are useful, especially to treat, to decrease the dose or to treat a side effect, anticipate side effect and how to treat it. Patient education is very important. Intervention is alternative. Cancer pain, remember, is a dynamic process. In the management or the dynamic process, it must have a dynamic management. Cancer therapy also relieve pain. So if you get a psychotherapy, if you get a chemotherapy, radiotherapy, surgery can treat the pain. Radiotherapy reduce the bone metastasis and it help in pain. Treatment of cancer pain is multidisciplinary, it is not one-man show. Opioid is a cornerstone for cancer pain. When analgesic fail or cause an adverse side effect, interventions is used. Non-pharmacological option can be a good option. Inadequate pain management continue to be affect cancer patient despite safe and effective option now. We have many options, as I told you, but still the many patient under treatment. While there are many barriers to pain management, as I told you, doctors, physician barrier, patient barrier, and ethical barrier or just governmental barrier. Clinician must be armed with knowledge about the cancer patient treatment, because if you don't arm it by knowledge, you will hurt your patient. Multimodal opioid adjuvant intervention used for the disease may be directed. Important than ever oncology team, and this is a teamwork, as I told you, must working with each other. While cancer affects the patient and not infected people around, cancer pain is a major issue for the family and the neighbor. I have one of the patient, the neighbor came with him because all the night he was screaming from pain. And as I told you, if you fail to treat cancer patient, just to treat the pain and let the patient to die in base. There are two types of pain in this world. Pain that hurt you and pain that change you. Thank you very much. It's my reference. And for any question.
شكرا جزيلا دكتور ياسر. انا يعني الحمد لله بفضل الله سبحانه وتعالى كنت متاكده 100% ان هي هتبقى ريفرنس لكتشر. كتر خيرك يعني محاضره رائعه وكل الناس مركزه ما شاء الله. هو مفيش حد اصلا خرج على فكره دكتور ياسر، بالعكس الناس زادت في الاخر.
عشان ناموا بقى.
لا انا اعتقد ان مفيش حد كان عنده وقت يكتب سؤال، لان هم كانوا مركزين عشان كمل المعلومات اللي هو جاي ورا بعض.
الحمد لله انا بعمل كده.
بفتح الفلور لاي حد عايز ياسك، ممكن يانميوت هيمسيلف ويسال. يعني ياسر الطيب معانا وشكله عايز يسالك، شكله كده. اتفضل يا ياسر.
ما هوش طيب ولا حاجه، انا قلت لك
لا طيب، طيب وجميل.
هو اسمه كده.
طيب وجميل. لا اتفضل يا ياسر.
اتفضل يا ياسر.
السلام عليكم.
وعليكم
وعليكم
السلام
السلام
ورحمة
ورحمه
الله
الله وبركاته.
وبركاته.
Allah يحفظك. Thank you very much, Prof, for this nice lecture. We really enjoyed every single bit of it. And actually, I would just like to take your opinion regarding the intrathecal and how much it is used in this Middle East area, because I know you work in many places, and I just want your personal opinion regarding the intrathecal pump in the cancer patient. Thank you.
Yes, I forget to tell you, this is a very advanced technique, like spinal implant, spinal neuromodulation. It need be a special center. But I was lucky because I went for training with Dr. Omar Tawfiq when he sent me to Netherlands many times for spinal implant, spinal cord stimulation. And when I returned back to Egypt, I have about 35 pump. I started to use it. And I make about 30 from the 32 pump, but one patient got infection. So I was a lecturer at that time. So all people who don't like to improve the surface attacking me. And the infection is about, in these people 22%. So one of the 30 is a very good standard to get an infection, because the patient, and again, it can be used you know that I use it in Egypt in many cases, and have many invention for that. You have and one very simple, like to put the pump and to make an under the skin, and to make like a wire coming to your hand like a clock, and to press every time to give a fixed dose. And there is another one that's called Isomed, which give a continuous, you adjusting the dose. Usually you hospitalize the patient and put an epidural, and to give the dose until to adjust it 3 days, 5 days, to see how much morphine you give it epidural to adjust the patient. For example, I give 10 milligram per day. So when I go for intrathecal, I give this 10 milligram become 1 milligram. And I divide it by day, but I don't give also the 1 milligram. I give half milligram and to grade it. And I think you are right. It's in Middle East. It's done very rare. It was done in Cancer Institute before, because I went to learn it, and they came back to do it. But because of the cost and complication, and selected patient needs selected patient, not done in Middle East like before. But I'm just telling you about all things. You may have good resources in good places, but this is we did that in Cancer Institute many times when I was in lecture there.
Thank you
I
دكتور
hope
ياسر.
to
تمام. دكتور سمير الكفراوي بيشكر حضرتك على المحاضرة، ودكتور خالد الجرمي زميلنا العزيز من ليبيا واخونا العزيز. احنا الفلور مفتوح لاي حد عايز يسال يا جماعه. unmute yourself and ask by yourself لو ما فيش وقت للكتابه. شكرا دكتور خالد الجرمي على حضورك، نورتنا. دكتور خالد، are you here دكتور خالد؟
ايوه معك دكتوره صفاء.
اتفضل.
شكرا جزيلا على المحاضره القيمه.
دكتور خالد، ربنا يبارك فيك.
الله يكرمك.
بارك الله فيك استاذنا.
الله يكرمك دكتور.
شكرا جزيلا.
حضرتك لك سؤال؟
لا دكتوره صفاء، بارك الله فيكم.
اوكي، الله يكرمك دكتور. بقى المفاجاه الجميله يا دكتور ياسر.
ان شاء الله.
الله يكرمك، نورت دكتور خالد. دكتور احمد السعيد علي. طبعا احمد السعيد علي، اتفضل.
دكتور احمد السعيد استاذنا طبعا.
اتفضل.
طبعا انا طبعا بشكرك يا دكتور ياسر، شكرا جزيلا. انا طبعا استمتعت بالمحاضره. شكرا دكتوره صفاء. تمام. ان شاء الله ربنا يجعله في ميزان حسناتك، وانت وحشني. تمام.
حاولت اكلمك النهارده يا دكتور احمد، بس ما حدش بيرد.
المحاضره اتجمعت بيزك وللناس اللي عاوزين يعني يعرفوا هاو تو مانج كانسر بيشنت. تمام. طبعا واللي ايده في الشغل طبعا عارف الحاجات، عارف يعني اموره مختلفه شويه. أنا كلام جميل جدا ومحاضره ممتعه يعني. شكرا يا دكتور ياسر كالعاده.
شكرا
يعني
يا دكتور احمد، ربنا يبارك فيك يا دكتور احمد. الله يكرمك. شكرا لك.
اللي عنده سؤال يا جماعه من الفلور، حد عنده سؤال؟
حد من معهد الاورام؟
استاذنا الدكتور محمد احمد كان موجود. حضرتك كنت عايز تسأل حاجة دكتور محمد؟
السلام عليكم دكتورة
اتفضل
صفاء.
عليكم السلام
اتفضل
دكتور محمد.
اتفضل.
دكتور ياسر، شكرا جزيلا على المحاضرة الجميلة جدا جدا
الله يبارك
جدا.
فيك، الله يكرمك دكتور محمد.
يعني بعيدة عن الفيلد بتاعي، ما بشتغلش بيه، لكن أنا صراحة يعني استفدت كتير.
الله
ربنا
يبارك فيك.
يبارك لحضرتك كالعادة. يعني محاضرات حضرتك كلها قيمة. ربنا يبارك
ربنا يبارك
لحضرتك،
فيك دكتور
وشكرا
محمد، ده
جزيلا
شرف
يا
كبير لنا،
دكتورة
شرف كبير
صفاء.
لنا
الله
ان حضرتك
يخليك،
تحضر يعني.
الله يخليك، الله يخليك.
دكتور خليل جمعة بيحيي حضرتك من العراق يا دكتور ياسر.
الدكتور خليل شاكو ماكو.
حضرتك ممكن unmute yourself دكتور خليل. دكتور خليل.
السلام عليكم.
وعليكم السلام دكتور خليل.
شكرا جزيلا على المحاضرة الرائعة، جدا جدا
حبيبي دكتور
رائعة.
خليل.
بس ردت أعرف التايتريشن مع الانتراثيكال دراكس that you give to patient. يس وجدا رائع، وأشكرك، وأنت إنسان رائع جدا.
ربنا يبارك فيك دكتور خليل شاكو ماكو.
الحمد لله ماكو شيء.
طيب الدوزز how to titrate, how to make the doses available for intrathecal pump. Most of the time when I get narcotic induced hyperalgesia, or the patient get a very high dose of narcotics and horrible side effect, but I don't have many options to use it. So the decision came for spinal implants. Spinal implants. So spinal implant, to adjust it, some people in some centers making a spinal dose, put a catheter spinal for 1 day, and to adjust the dose, to titrate the dose until to get the result. But most of the physician, and this is what we did in Cancer Institute before, put an epidural catheter, because epidural catheter can put it in 3 to 5 days. And I titrate the dose. I give, for example, he get a very horrible dose. I give, if he get, for example, the patient 60 milligram per day, oral. So when I give 60 milligram oral, the availability is 1/3. So I give 20 milligram IV. So I give 2 milligram epidural per day. And from this 2 milligram I started with, I can increase or decrease. I started with, usually we started, if you account 2 milligram, I started half of the dose. I give 1 milligram per day. First day, the patient control is okay. Second day, but if not control, I titrate for this 3 to 5 days until I get the optimal dose for the patient. And after that, I know that from that epidural to intrathecal is 1/10. So if I give 1 milligram epidural, he need about 0.1 milligram morphine per day. So I divide it, and some people just decrease it. But the most important thing to titrate until you get the effect, and it takes from 3 to 5 days to get an optimal dose for the patient. And sometimes this catheter, after some time, it need what's called to increase the dose. And sometimes it can be blocked, it can be break. It need a follow-up, a very good assessment and follow-up. And sometimes infection happen, with the catheter or the implant itself. So to titrate it, to put the patient, to put an epidural, to adjust the dose, to look how much he take an oral, to divide it to 1/3 of IV, to divide it, after that, 1/10 and 1/10 until you get the intrathecal dose. I hope to answer.
Thank you, Dr. Khalil Karim, for your attendance to us. Karim Mekhemer have a question. Okay.
السلام عليكم يا دكتور ياسر، ازي حضرتك؟
وعليكم السلام يا كريم، الله يكرمك.
كنت عايز اسال حضرتك على الرول بتاع البي سي اي، لان احنا خصوصا في مصر عندنا مشكله في الترانسديرمال باتشز، يا اما مش موجوده يا اما غاليه جدا، واللولي بوبس برضه نفس الكلام. فهل البي سي اي رول والعيان يقدر ياخدها البيت معاه ولا لا؟ يعني what about the guidelines في الموضوع ده؟ شكرا دكتور.
هو انا عاوز اقول لك يا كريم ان في بعض الحتت ده موجود، يعني حتى في بعض الحتت بنروحوا يعني عندنا واحد هنا اللي هو الAMS بتاع الاسعاف، عنده شولدر، يعني كان بينقذ حد عربيه دخلت فيه هو في. فالمهم ان هو عنده shoulder problem every now and then, but he's an educated and he's an MS. Sometimes when he make a shoulder surgery or put a catheter, and we take the pump, and because he can't deal with the pump. You know, many factors affecting that. If the patient near the hospital, if anything happen, or far away from the hospital, the patient educated to use it or not. Some country prohibited that because the patient can kill himself. And some area, if you have people to check and to follow up, it can be used. But I think in Egypt it's very dangerous because you need an educated person how to take a morphine, because you know any dose can kill the patient, you know. So he need in some areas the people educated near the hospital and he know everything. And you know that there's a pain teaching nurse. We have a pain teaching nurse. So if you have a pain teaching nurse teaching the patient about everything, and like to be a license to use this machine. And in some country accepting that and teaching the people, but I think it's very dangerous with an low socioeconomic country with needed training, and it will put you in medical legal problems. And I don't know the law accepting or permitting or not. But anything, I think it will be a problem to you.
Thank you, Dr. Yasser.
شكرا كريم. دكتور ياسر مع بروف أماني عمار، بروفيسور اوف انستيزيا اند بين مانجمنت في المنوفيه يونيفرستي، وهي كورس اور نيكست كورس اورجنايزر، وهي معانا وهي تسلم على حضرتك، ويعني منوره دايما وعامله لنا دعم غير مسبوق. اهلا وسهلا اماني حبيبتي.
ان شاء الله، وندعو الناس اللي موجودين ان شاء الله يحضروا كلهم ريجونال والبين ورك شوب ان شاء الله.
ان شاء الله. اتفضلي يا اماني، اتفضلي.
شرف بوجود حضرتك معانا في المنوفيه يوم
اهلا وسهلا يا فندم، ده شرف كبير لنا والله.
ان شاء الله، وان شاء الله الكل هيكون موجود، وشرف استقبال حضرتك ونستمتع بالمحاضرات الجميله والكورس الجميل اللي حضرتك هتقدمه لنا ان شاء الله.
يا فندم ده شرف كبير لنا والله نكون دكتور مصر ان شاء الله.
الله يكرمك دكتور ياسر، منتظرين حضرتك ان شاء الله.
ان شاء الله. شكرا يا فندم.
شكرا يا امين. شكرا يا فندم. شكرا.
شكرا دكتور.
في سؤال؟ حد بيسأل؟
شوف بعد اذنك
اتفضل. بسام who want to ask؟
بعد اذنك دكتورة صفاء ممكن اسال مرة ثانية؟
اتفضل. طبعا
إذا ممكن يعني. الله يحفظك. Just a comment from Prof. Yasser Rida regarding the cancer patients who are for surgery, because I read some topics regarding using the regional for these cancer patients. It may help in preventing the recurrence of the cancer itself. So will he please give us some insights regarding this? Thank you.
Yes, in many, this is become a common belief that this is one of the advantage of regional anesthesia. If you use a general anesthesia, usually using narcotics, and narcotics prohibited the immune system. And in many studies, like a liver surgery, I found many studies about liver surgery or colon surgery. They found the recurrence increase with general anesthesia, especially when using the narcotics. And one of the advantages of regional anesthesia is that the recurrence become less and less. It wasn't just before and not and some sort of evidence, but now have an evidence, because many surgery for colorectal, for liver, and it done many study and proving that with an regional anesthesia the recurrence is less. With general anesthesia, especially with narcotics, the recurrence rate is very high. And that's right, yes, and many studies now showing about this, and this is one of the advantage of regional anesthesia now. Whenever you can use it, use it. Whenever you don't like to use a narcotics to inhibit the killer cell, do that if you can.
Thank you, boss. Thank you.
Okay.
Thank you, yes. Any more question from the floor? So now it is my time to ask.
Yes.
Dr. Yasser, I know that you are interested in artificial intelligence and nanotechnology and precision medicine, and I know you are going deeply through this issue. So as Professor Mustafa Kamel, this is a professor of oncology, Egyptian professor, and he studied, he do an amazing thing about the gold nanoparticles in treatment of cancer pain. Shall we have in near future an analgesic or whatever opioid or non-opioid to be particulated, mini particulated, and we can use nanotechnology in treatment as a method of analgesia in cancer patient? You read something about that?
You know, the dream of yesterday is the reality of today.
Yes.
So, you know, the technology progressing very fast.
Yes.
على رأي ميلودي مش هتقدر تغمض عينيك.
Yes.
And it's coming very fast, and now it's using, and there's many research about even genetic therapy to treat the pain, or just to treat the to attack certain gene to treat the pain or treat the cancer, to prevent the cancer. And now I remember all the time when that medical pharmacology or clinical pharmacology was preparing the drug with a certain method, or to give in a dose to decrease the doses for others. And now with nanotechnology, you can put a carrier, put your medication in a carrier to go for a target area for the cell to work in it. And this is progressing very fast. And I think in near future, very near future, you will find that. You know, like first time I see, I just was going for my doctor and psychiatry was in the upper floor. I found a lady holding something in her hand and shouting in her hand. And I think this is a crazy woman coming for psychiatry. And after many days, I discovered this is a mobile phone. It was a very big one. So it is progressing very fast. And the technology and nanotechnology progressing very fast. And what you see in the American movie about the future, it will be a reality second day. And even beyond your expectations, everything going very fast, because some company, they have the future, but bring step by step, just for economic purpose.
Yes, yes. You mentioned that methadone and buprenorphine. I suppose both drugs are very useful, especially in patients liable to have drug dependency syndrome or addiction from the chronic use of narcotics in cancer patients. They will depend on opioid if we start to buy it for many times. So liability of some patients, like those elderly or those with chronic pain or psychiatric problem, may have drug dependency syndrome. So methadone and buprenorphine has a valuable chance in those patients to diminish and mitigate the liability to be addict or drug dependent for narcotics. But as methadone causes prolonged QT. So as you said, Professor Yasser, that this prolongation may cause the arrest under anesthesia, and so we should prepare ourselves when giving methadone to our patients.
Yeah, yes, sure. This is a right fact, but the very important fact about cancer pain, don't be restricted. Don't fear from addiction in this patient, because life expectancy usually not very high, especially in advanced cancer when you have a severe pain. So don't let the thinking about addiction to prevent it to treat the patient. This is like a scale. You are walking in the very thin rope. So take care, you know, you must treat the patient. But you are right. If this non-cancer patient, you are right. I'll be more conservative. But with cancer patient, you are right. Less addiction with the buprenorphine, and sometimes use it and morphine and methadone to decrease the doses or to change. Even I found the chance to make it in opioid rotation. When I found an opioid rotation, the patient not helping by medication, I found this is a good chance to do that, because less addictive power with buprenorphine and with an. I have many patients, you know, when you get a severe pain in some stages, they take buprenorphine for 2 weeks, and is very good now. I don't take it, leave it for 2 months, and can take it when but don't have what's called. And usually this not happen as happen in chronic pain. In cancer pain, addiction not happen, and this is a mercy from Allah, because I don't know, I don't have an clinical explanation, but what I feel that if you have a pain and take narcotics, all the drugs, this is the explanation from me, all the drugs going for the pain receptor, which is fire, and very little drug to go for other area like GIT or brain. But if you take the medication just for satisfaction, all this medication go for this area. You can get all the side effects. So the side effect in cancer patient is less and less more than the chronic patient. And this is a mercy from Allah for these people.
Yeah, yes. يعني في حكمة أنا يعني فاكراها من أيام ما كنا بنذاكر فارماكولوجي، كانت بتقول إن yesterday I was suffering my disease but today I am dying by my medications.
Yes.
So tailoring the medication for our patient, either cancer patient or chronic pain patient, we should tailor the drug which is useful, which is more important, which will have the high efficacy in this type of patient. Am I right, Dr. Yasser?
Yes, yes.
Yes.
Tailor it's like anesthesia must be tailored on the patient. Your medication for pain must be tailored on the patient, and some patient not responding for other drugs. Some people, the same disease, the same person, the same everything stage, and he responding very good, and the other one not responding at all. As we speak about artificial intelligence genetic management, because different in everything in genes. It's like a fingerprint, like an what's called the stamp for the eyes, even like fingerprint. Everyone different. Every creation different from the others.
Yes, yes. As regard the care of terminally ill cancer patient, and as you mentioned, and our great Professor Yasser Zaghloul mentioned in his a post on Facebook about Professor Paolo Pilosi and the virtual role of relations and etc. Of course, this type of patient, even before going to the terminal stage, when diagnosed differently to be a cancer patient, we should support them initially before any medication. This is because it is disaster news, and it is may make him unfortunately sense of fear of death. All his important issues and all his family, all these things will be upside down. So I suppose that the psychological support should be initially, even before medication.
Yeah, I agree with that. Especially our culture in Arabic, you know, most of the patient family come with him. Don't tell him they have a cancer. Don't tell him. I don't know, but this is in West country is not permissible. You must tell him about everything, about the progress of the disease, the future. But here in our Arabic culture, it may be different, because if you tell her like this, he will die sometime. You know, I look for the signs. I look for him, and many people don't tell him. You know.
ممكن يجي له بروكن هارت اصلا من الدياجنوزيس نفسه، مور ذان ان هو يبقى فعلا تعبان للدرجه دي او الكلام ده، رغم ان هو ممكن يبقى كيورد وكويس جدا بعد كده وما فيش اي مشكله. فانا في رايي ان احنا نعمل السايكيك سبورت ده انيشيالي من الاول، واحنا الحمد لله معظم الناس يعني قريبه من ربنا سبحانه وتعالى وبتستقبل الاخبار ديت بشكل يعني مطمئن لله ولحسن الظن بالله سبحانه وتعالى وتمام الشفاء. لكن اعتقد ان الدور بتاع الجانب الروحي في العلاج عندنا في الكوميونيتيز بتاعتنا لازم يبدا early مع الدايجنوستس.
هو يعني there is a very important topic here. When we speak about our culture, it's totally different from outside. Outside, some people ask to be died, to kill me, like euthanasia, omega euthanasia. I don't need a ventilator if I'm don't resuscitate me. And also because lack of believing in Allah and the other life. Some people, you know that if you read in the book about cluster headache or trigeminal neuralgia, you found that the suicidal tendency about 20% of the people. And I was in training somewhere. I found people jumping from the high building and 28 years old because trigeminal neuralgia. But this never happened in our country because the people have a belief, and you know that if you killed yourself, you will be punished in the other life, and you know it's not happening here, and the people can't tolerate the pain more than the other people. But when I speak about our culture, I don't speak about don't resuscitate the patient, ask not do anything for me or just to kill me, that doing in Sweden or Norway for euthanasia. When I just get tired from them cure, just kill me. by certain methods. This is not an not an here in culture and religion. Our religion don't accept it, whatever Christianity or just Islam or even Jews don't accept in that for our life. So the spiritual support is very important, and they already give us support without anyone to telling you about your disease.
Yes. Anyone from the floor have a question? Anyone from the floor have a question? We have a question from, I don't know exactly who is that. Does clonidine have a role as adjuvant like narcotic in cancer, pain, or better not to use?
To that time, I found a very little literature about using in as adjuvant for nerve block and all this stuff, but it may be in the future have a very great role, because as clonidine or dexmedetomidine is starting to be a bear in even anesthesia for analgesia, used first as a drug for hypertension, but as many drugs used for something and found in better thing and other thing. But most of the study in cancer patient, as I told you, this is not a great evidence because of most of the study done for animal study and can't make a study in human. It maybe have a role. I found some thing speaking about cancer, and but this is one of the option. You can use it, but it need an to be in high scale, it need more evidence and more study, and we don't have this more studies. I have a very little study about it. I see one of the studies speaking about to use it like infusion with a narcotic, to use mixed narcotics, because spinal implant, sometimes you use an, especially with drug-induced hyperalgesia, you can use a very low dose of levobufotenin with an narcotics and even with clonidine. But it need more study to be and showing. And when it become a common practice, you cannot do it. Or you can make a study, but it's very difficult for you to make a randomization in our countries. Even here in Qatar, you can very difficult to make a randomization. You can't tell the patient, I will not give you anything, or I give fluids, I will see. No one accepting that. It need a volunteer, and this volunteer take a money for that. And the study will be very expensive, and don't have this in our country.
انا مش فاهمه كويس، هل هو السؤال قصده ان هو بيعملوا كاداتيفز مثلا في الانتراثيكال او في الانترفنشن، ولا ايه بالظبط؟
هو can use as an analgesia. هو can be used an IV analgesia, can be perineural analgesia, can be intrathecal, because many people use an intrathecal clonidine and dexmedetomidine. It's a long time, even not approved by FDA, but it's approved now, clonidine for perineural. Even dexamethasone not approved, but and clonidine, if it's approved, this means that the dexmedetomidine will be approved, because this is a higher version from the medication. But some drugs are not approved. It can be used, and many people use in spinal or intrathecal, and very effective. But still, what is the best dose to prevent the hypotension, bradycardia? Still just under study, you know. But it's a very good analgesic drug, you know, especially if used with local anesthesia. And also spinal implant, you can put another drug. It can be give infusion of local anesthesia, a small dose of levobufotenin or lidocaine or whatever. It can be, but it needs more study to show the safety and the dose, the optimal dose and side effect about that.
Yes. Again, the same question about the BCA as a home medication in cancer patients.
You know, as I told you, it needs a legal issue according to the law of the country. In some country can give it, but you know, this patient is educated, get studies, get a lessons like education about the pain management. The patient educated about everything, and the patient have a vent for escort for transportation immediately if anything happen, and there is a caregiver for the patient. But if you don't have that, it will be a problem, especially our patient I think in Egypt, to make a problem, many problem. I think is that someone tell me that one died by this medication, you know. So it need a legal issue to be, and not just save the patient, save yourself, to protect yourself about the legal issue if it happened. So it need a law and to adjust it with requirement, because here we have one patient we give him, but other patients don't give him, you know.
Yeah,
but
the question was Clonidine. I'm asking about using it in BTA home medication. ولاء هي اللي بتسأل على كانت السؤال بتاعها جمعيه دلوقتي، فبتقول هل تقدر تقاد كولينيدين للبي سي اي ويتاخد هوم في الهوم يعني؟ ولاء هي اللي بتاسك الموضوع.
but you need to adjusting the dose to be a caregiver there, especially if you have a nurse.
Yes,
you know, some patient can offer a nurse, can offer everything to be controlled, but if you do that alone without anything, you can kill the patient very easily.
Still, we have not enough studies to confirm this.
There is requirement to use the BCA in home. This requirement, patient education.
She asked about the addition of clonidine in BCA and take it in home, the BCA, after adding clonidine to the other component. Clonidine in BCA.
You can. I speak about BCA, whatever you add or not add, whatever morphine, whatever the drug, any drug. This is a problem. If anything happen, it can happen. It will be a problem to you. Why you put yourself under the law? Why?
Yeah.
You know, and you know, and this terminal care patient in America, for example, they make a hospices like in places like a hospital, but in far away from the city, maybe in jungle or in special area, and these people treated for terminal care people, and they can give them BCA, they have a nurse, they have doctors, they have everything, can control.
They have special caregivers in their home.
Because I hear some surgeon based on anesthesia to do that.
Yes,
some surgeon based on anesthesia to do that. This is a very wrong practice until you have a law which protecting you. If they have a law now, can protecting you, they remit the patient and to go on his responsibility, it's okay. But anything happen, even the people attacking you without doing anything. What if anything happen here? What you can do?
Yes. We have a question from our dear son, Yasser Hassan, is about asking about the usage of ketamine infusion as a role in cancer patient treatment.
ketamine infusion intrathecal ولا epidural ولا IV؟
IV مش كده يا ياسر؟ طيب.
ما هوش طيب ولا حاجة أنا قلت لك. ما هوش طيب ولا حاجة. يعني
الشرير طيب وجميل.
لا ده هو كويس إن قاعد معانا لحد دلوقتي، المفروض يروح ينوم بقى. طبعا الكرونيك بين you have a role for IV lidocaine if you don't have other facilities. You have a role for IV what's called the clonidine or dexmedetomidine. You have a role for ketamine, especially in some patients. But for cancer, as a cancer, some patients cancer have, for example, have complex irritable syndrome for the limb, for cancer breast. It can be tried if you don't have, do everything. Usually you do the thing is common. I don't speak about evidence because most of the thing is lacking evidence in pain management. But it's common, used for a high scale. And if you use all the bottom in the plane and not like what's called you can't what's called landing, just use a bottom in your jacket. So it can be used. We use it in many cases, but mostly if complex irritable syndrome and interstitial cystitis, very effective. The patient can for 1 month can control. If you give him 50 milligram in 1 hour or 2 hours infusion, it works very good. And it can be used in your patient if you don't have other alternative to do. Just to try it because they have a role in chronic pain, And but it needs hospitalization, it needs monitoring, something like this, You can't make it in any place. So it can have a role.
Yes. Any question from the floor? Any question from the floor? Everything is okay for all my great friends.
Just if you remember anything, if you need to ask, I have here my 2 email, the official one and personal one, and I have my phone number. So whenever you have anything in your brain want to ask, I will just reply you after 1 or 2 days, inshallah.
Everything is okay for all our colleagues attending this outstanding and fascinating lecture. Thank you, Dr. Yasser, for your time and
Thank
effort.
you, Dr. Sabah. شكرا
جزيلا. جزاكم الله خير. كتر خير. كتر خير. شكرا جزيلا لكم جميعا. شكرا جزيلا.